Have you ever had one of those leg cramps that just, digs in and won't quit? Or maybe a weird visual thing, like a flicker or shadow that made you think, huh, what's that about? Our bodies, they're this incredible, complex network, right? Arteries, veins, constantly moving blood around. But sometimes things can go a little sideways in that system, and the signs, they might be subtle, or sometimes really quite dramatic. Today, we're doing a deep dive into the honestly pretty critical world of vascular diseases. We'll be unpacking things like peripheral arterial disease, you'll often hear it called PAD, and a whole bunch of other conditions affecting arteries and veins, some common, some surprisingly rare. And these can impact everything, really, your legs, your arms, even up to your brain and heart.
Yeah, and to help us navigate all this, we've been looking through quite a bit of detailed medical information, research summaries, that kind of thing. Our goal, really, for you listening, is to give you a clear, pretty concise handle on these complex issues. We want you to walk away feeling like you can sort of tell these conditions apart, recognize the really crucial signs, hoping for those aha moments where the dense medical stuff just clicks.
Okay, great. So let's start unpacking peripheral arterial disease, PAD. What exactly is going on in the body there?
So PAD, at its heart, it's atherosclerosis. Think plaque buildup, hardening of the arteries. But specifically, it's happening in the arteries away from the heart out in the periphery. Most often, we see it in the lower extremities, the legs.
Okay. And if someone has it, how would they likely feel it? What's the number one symptom?
The hallmark symptom is definitely claudication. It's that pain or maybe cramping in the leg or buttock that specifically comes on when you're moving, walking, exercising. And here's the absolute key. It predictably gets better when you stop and rest. That pattern, pain with activity, relief with rest, that's a huge clue.
Right. It's almost like a diagnostic test in itself. Does the location of that pain tell you anything more specific, like which artery might be having the issue?
Oh, absolutely. It's very informative. If the pain is high up, think buttock, hip, maybe the groin area that often points towards the bigger arteries like the aortic bifurcation or the common iliac, maybe about 25–30% of cases. And there's actually a specific syndrome linked to that area, Leriche's syndrome. It's this interesting triad. You get the claudication, specifically buttock and thigh pain, combined with the erectile dysfunction, and also decreased pulses down in the groin, the femoral pulses. It's quite specific.
Wow. Okay. And what if the pain is more in the thigh or, say, the upper part of the calf?
That usually points to the femoral artery. And that's actually where we see PAD most often, something like 80–90% of the time. It's very common there. If the pain is lower down, like the lower third of the calf, down towards the ankle and foot, then you're probably looking at the popliteal artery behind the knee. And if it's really just focused in the foot itself, that typically involves the tibial and peroneal arteries. Around 40–50% of cases involve those.
So that classic claudication is key. But are there other kinds of pain? Maybe something indicating it's more advanced?
Yes, definitely. Sometimes people have what's called atypical extremity pain. Maybe not severe enough to make them stop walking, but still there. But the really critical one to know about is ischemic rest pain. This signals pretty advanced disease. It's often described as this constant, really bothersome, burning pain, usually in the forefoot. And characteristically, it gets worse at night, especially if the leg is elevated. But here's a really important distinction, kind of counterintuitive. It often feels temporarily better if they dangle their foot down over the side of the bed. Foot dependency, using gravity to pull a bit more blood flow down.
That's a fascinating detail. So when a clinician is examining someone they suspect has PAD, what are they physically looking and feeling for?
Well, checking pulses is fundamental. Are they weak, decreased, maybe even absent altogether? They might listen with a stethoscope for Brutes that's like a whooshing sound. It indicates turbulent blood flow, like water rushing through a narrowed pipe. It means the flow isn't smooth. They'll check capillary refill time too. And importantly, this is a big differentiator we'll come back to. You usually don't see significant edema or swelling with PAD itself.
Right. And the skin, you mentioned it, tells a story.
Oh, absolutely. The skin can really show signs of poor circulation. You often see what we call atrophic changes. That means muscle wasting or atrophy. The skin itself might look thin, very dry, kind of shiny. You can see hair loss on the leg or foot, or maybe slowed growth of hair and toenails. Nails might get thick and brittle. And the limb itself often feels cool or even cold to the touch compared to the other side or the rest of the body. In severe cases, you might even see areas of necrosis, which is tissue death.
And those wounds that just won't heal.
Yeah, exactly. Ulcers are a major concern. Often they start as just a small cut or scrape, maybe from bumping the foot, but because the blood supply is poor, they just fail to heal. You commonly find them on the tips of the toes, sometimes between the toes, or over pressure points like the outer ankle bone, the lateral malleolus, or the heads of the metatarsal bones on the ball of the foot.
Okay. And color changes. You mentioned pallor.
Right, pallor or paleness, especially when you lift the leg up. Gravity drains the already limited blood flow, but then when you lower the leg, you might see something called dependent rubor. The foot turns this dusky, reddish-purple color. That happens as the small vessels dilate, trying desperately to get more blood flow, and it can temporarily ease that rest pain sometimes.
So how do you actually diagnose PAD? What's the go-to test?
The most useful screening test, hands down, is the ankle brachial index, or ABI. It's great because it's simple, it's fast, totally non-invasive. You just use a blood pressure cuff and a Doppler probe. A normal ABI reading is generally between 1.0 and 1.3. If the reading is less than 0.90, that's diagnostic for PAD, and if it's really low, like less than 0.50, that indicates severe PAD.
Okay, less than zero point 0.9 is PAD, but what if it's higher than 1.3? Does that mean everything's perfect?
Not necessarily. That's a really important point. An ABI above 1.3 can actually mean the arteries are calcified, they're stiff and non-compressible. So the blood pressure reading in the ankle might be falsely elevated. So if the ABI is abnormal or inconclusive, or if we need more detail, duplex ultrasonography is often the next step. It lets us visualize the blood flow and look for areas of low velocity or blockage. And then arteriography, where dye is injected, that's considered the gold standard or criterion standard for visualizing the arteries. But it's invasive, so it's usually reserved for when a procedure, like an angioplasty or bypass, is being planned.
Got it. So moving on to managing PAD. What are the first things people should focus on, the foundational steps?
Okay, first-line treatment is really about supportive care and risk factor reduction. That means getting things like high cholesterol, hyperlipidemia, and diabetes under control. Supervised exercise therapy is also really beneficial for improving walking distance. But the absolute #1 game changer, smoking cessation. Quitting smoking is associated with the greatest benefit in PA. It's the single most important modifiable risk factor for coronary artery disease, too, which often goes hand in hand with PA.
That's such a critical message. It sounds like many people might initially brush off those cramps as just aging, but these changes are crucial.
Absolutely. And then medication-wise, we think about protecting the cardiovascular system overall. So platelet inhibitors like aspirin or clopidogrel, they're standard. They have reduced the risk of heart attack and stroke, which people with PAD are at higher risk for. Statin therapy is also recommended for pretty much everyone with PAD for the same reasons, cardiovascular risk reduction. Now, specifically for improving the symptoms of claudication, for helping people walk further without pain, the medication cilostazol is considered the most effective medical therapy.
Cilostazol. I remember reading it has some interesting ways it works. It's not just one thing, right?
No, it's quite fascinating, actually. It works through several mechanisms. It inhibits platelet aggregation, so it makes platelets less sticky. It's a direct arterial vasodilator, meaning it helps relax and widen the arteries. It also seems to increase the flexibility of red blood cells, which might help them squeeze through narrowed areas better. And it suppresses the growth of smooth muscle cells in the artery wall, which contributes to plaque buildup.
So it's tackling the problem from multiple angles to improve that walking distance.
Exactly. It's a real workhorse for improving quality of life when claudication is the main issue.
And if lifestyle changes and medications like cilostazol aren't quite cutting it, or if the disease is more severe, that's when interventions come in.
That's right. If someone has that ischemic rest pain we talked about, or if their symptoms are really limiting despite medical therapy, or if they have non-healing ulcers, then revascularization is considered. Percutaneous transluminal angioplasty, basically using a balloon to open the artery, sometimes placing a stent that's often the first-line approach. Bypass grafts, surgically creating a detour around the blockage, or endarterectomy, surgically removing the plaque, are other options, usually for more extensive disease.
Okay, so that covers the more chronic progression of PAD. But what about situations where an artery issue is sudden, acute, a real emergency?
Right, that's acute arterial occlusion. Yeah. And this is a true vascular emergency. Time is critical. It can happen in two main ways. Thrombotic occlusion is actually the most common, where a clot suddenly forms right there in an artery that was already narrowed by POD. Or it can be an embolic occlusion. That's where a clot forms somewhere else, often in the heart, maybe due to atrial fibrillation, breaks off, travels downstream, and then gets lodged in a narrower artery, blocking blood flow suddenly.
And when that happens, that sudden lack of blood flow, what are the immediate critical signs, the red flags?
Yeah, there's a classic mnemonic for acute limb ischemia, the 6 Ps. It's really important to know these. They are Paresthesias, that numbness or tingling, often one of the very first signs. Pain, usually severe and sudden. Pallor, the limb looks pale, white. Pulselessness, no pulse felt below the blockage. Poikilothermia, the limb feels cold compared to the other side. And finally, paralysis, inability to move the foot or toes, which is a very late and dangerous sign. And typically these symptoms are felt distal to or below the level of the actual blockage.
Okay, the 6PS. Sounds critical to recognize. If someone shows up with those signs, what happens next?
It's an immediate evaluation. Often starts right at the bedside with a handheld Doppler to check for flow. Then usually a duplex ultrasound, maybe angiography to pinpoint the blockage. But treatment needs to start immediately. The first step is anticoagulation, usually with IV heparin, to prevent the clot from getting bigger or new clots forming. Then, revascularization restoring blood flow is the main goal. That might involve clot-busting drugs delivered via catheter or surgical removal of the clot or bypass. Unfortunately, if the tissue damage is too severe and irreversible, amputation might be the only option, but that's really the last resort.
Okay. So, moving beyond PAD and acute occlusions, are there other, maybe less common, but still important artery conditions we should touch on?
Yeah, there are a few interesting ones. One is thromboangiitis obliterans, probably better known as Berger's disease. What's really striking about Berger's is who it affects. Typically young men, often between 20 and 45. It's seen more often in places like India, Asia, the Middle East, and it has an incredibly strong link to tobacco use. Smoking, chewing tobacco, any form.
So it's not atherosclerosis like PAD.
No, exactly. It's a non-atherosclerotic condition. It's an inflammatory vasculitis, inflammation of the blood vessel walls, affecting the small and medium-sized arteries and veins, mostly in the arms and legs. Clinically, it often presents as a triad. You see signs of distal extremity, ischemia, so painful ulcers or even gangrene on the fingers or toes, maybe claudication pain, but uniquely, often in the arch of the foot. Second, Raynaud's phenomenon, that color change in finger toes with cold or stress. And third, superficial migratory thrombophlebitis clots and inflammation in superficial veins that seem to move around.
That sounds quite distinct. Is there a specific diagnostic test or finding for Berger's?
On imaging, like an aortogram looking at the vessels, you can sometimes see this characteristic corkscrewing appearance of the smaller collateral arteries that form. It looks quite different from the blockages you see in PAD. But honestly, the diagnosis relies heavily on the clinical picture and excluding other causes. And the absolute cornerstone of management, strict, complete cessation of all tobacco use. Nothing else really works effectively if the person continues to use tobacco. It's paramount.
Okay. And you mentioned a cardiac condition that can cause arterial problems, atrial myxoma.
Yes, this is actually the most common primary tumor of the heart itself. About 80% of them occur in the left atrium. They're often pedunculated, meaning they're on a stalk and they can swing around. What's really interesting is they can cause a ball valve effect, intermittently blocking the mitral valve opening between the left atrium and ventricle. This can actually mimic the symptoms of mitral stenosis.
Mimicking mitral stenosis. So what are the symptoms then? Is there a triad here too?
Yeah, there is. First, you can get embolic phenomena. Because these tumors can be fragile, bits can break off and travel through the bloodstream, causing strokes or blocking arteries elsewhere. That's a major risk. Second, you get those mitral stenosis-like symptoms, shortness of breath, fatigue. And third, people can have constitutional symptoms, kind of vague flu-like things, fever, weight loss, joint pain. Because of that high risk of embolization and other potential cardiovascular complications, including sudden death, prompt surgical removal is almost always recommended, even though most myxomas are technically benign, not cancerous.
Right. Okay, one more arterial condition to cover, and this one sounds like it needs urgent recognition. Giant cell arteritis, or GCA.
Yes, GCA, sometimes called temporal arteritis. This primarily affects older adults, usually women over 50, with the peak age around 70 to 79. It's more common in people of Northeastern European or Caucasian descent, and again, there seems to be a link with smoking. It also frequently overlaps with another condition called polymyalgia rheumatica, or PMR, which causes muscle pain and stiffness in the shoulders and hips. The most common symptom, seen in about 75% of people, is a new onset headache. Often it's located over the temples, and the scalp might feel tender to the touch.
And isn't there a specific type of pain associated with chewing?
Yes, that's jaw claudication. It's pain or fatigue in the jaw muscles that comes on while chewing, or sometimes talking, and gets better when they stop using the jaw. It's caused by ischemia, lack of blood flow, to the masseter muscles used for chewing. But the most feared complication The reason GCA is such an emergency is the risk of permanent vision loss. This can happen in 15–25% of patients if it's not caught and treated quickly. It's usually due to ischemic optic neuropathy. The optic nerve gets damaged from lack of blood supply. People might also experience amaurosis fugax, which is transient macular blindness, like a curtain suddenly coming down over one eye, then lifting again. That's a major warning sign.
Wow, permanent vision loss. So diagnosis and treatment need to be fast.
Absolutely critical. Diagnosis is often suggested by those symptoms, plus markedly elevated inflammatory markers in the blood. The ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, are typically very high. But the key management point is this. You must start high-dose systemic glucocorticoids, like prednisone, immediately as soon as you suspect GCA. You cannot wait. The goal is to prevent blindness. Treatment should not be delayed to get a temporal artery biopsy, which is the definitive diagnostic test. The biopsy can still be positive even if steroids were started up to 2 weeks prior. Reducing inflammation quickly is the priority. There are also newer options like IL-6 inhibitors that can be used as well, especially for long-term management or if steroids cause problems.
Okay, that's a vital point about immediate treatment for GCA. Let's switch gears now and move over to the venous side of things, starting with superficial thrombophlebitis. How is this different from just, say, phlebitis?
Good question. So phlebitis just means inflammation of a vein. Superficial thrombophlebitis specifically involves that inflammation, plus the formation of a thrombus, a blood clot, within a superficial vein, one close to the skin surface. It most commonly happens in the great saphenous vein in the leg.
And what puts someone at risk for this? Is it just having varicose veins?
Varicose veins are definitely a major risk factor, but it can also be associated with IV catheters, trauma, pregnancy, and importantly, underlying malignancy or hypercoagulable states, conditions that make blood clot more easily. There's actually a specific sign, Trousseau sign, which refers to migratory thrombophlebitis, having clots pop up in different superficial veins over time. That pattern is particularly associated with underlying cancer, often pancreatic cancer. It's a potential clue to look deeper.
Interesting. So how is it diagnosed, and is there a link to the deeper veins?
Diagnosis is often clinical. You can see and feel a tender, red, palpable cord along the course of a superficial vein. But venous duplex ultrasound is really important, not just to confirm the superficial clot, but crucially, to rule out a coexistent deep vein thrombosis, or DVT. There's actually a surprisingly high rate of DVT occurring along with superficial thrombophlebitis. And that's critical because DVT carries the risk of pulmonary embolism, PE, where the clot travels to the lungs, which can be life-threatening. Studies suggest PE occurs in maybe up to half of patients who have DVT. See if you check for it. Management for superficial thrombophlebitis itself is often supportive of warm compresses, elevation, NSAIDs for pain. Anticoagulation might be used depending on the clot size, location, and risk factors for DVT.
Right, that connection to DVT is key. So let's talk about DVT itself, deep vein thrombosis, often called the hidden threat. What are the underlying causes?
Yeah, the classic way to think about DVT risk factors is Virchow's triad. It's named after the physician who described it. It consists of 3 broad categories that promote clot formation. First is intimal damage, meaning injury or inflammation to the inner lining of the vein. This could be from trauma, surgery, infection, or inflammation. Second is stasis, which just means slowed blood flow. Think about immobilization after surgery. Long plane or car ride sitting for more than 4 hours, paralysis from a stroke, even just prolonged bed rest. When blood isn't moving well, it's more likely to clot. And third is hypercoagulability. This means the blood itself is more prone to clotting. This can be due to inherited genetic conditions like factor V Leiden or protein C and S deficiencies. Or it can be acquired things like oral contraceptive use, hormone replacement therapy, pregnancy, underlying cancer, and yes, smoking again.
Okay, Virchow's triad: damage, stasis, hypercoagulability. What symptoms should make someone suspect a DVT?
The most common presentation is unilateral leg symptoms, meaning just one leg is affected, usually swelling, pain or tenderness, warmth, and sometimes redness or erythema. Now, lots of things can cause leg pain and swelling, but the most specific physical exam sign for DVT is significant unilateral calf swelling, usually defined as a difference of 3 centimeters or more in circumference compared to the other leg, measured about 10 centimeters below the bony bump on the shin, the tibial tuberosity. You might hear about Hohmann's sign pain in the calf when flexing the foot, but it's really not considered reliable or specific for DVT anymore.
So if you suspect it, how do you confirm it? What's the main diagnostic test?
The first-line test and the diagnostic test of choice is venous duplex ultrasound, specifically compression ultrasonography with Doppler. The ultrasound probe is used to push on the veins. Normally, veins compress easily. If a vein doesn't compress, it indicates there's a clot inside that's the key finding for diagnosing DVT. The Doppler part assesses blood flow. There's also a blood test called D-dimer. It measures a substance released when clots break down. A negative D-dimer in someone considered low risk for DVT based on clinical scores can be useful to help exclude a DVT. But a positive D-dimer is less specific. Lots of things can cause it to be elevated. So if it's positive or if the clinical suspicion is moderate or high, you typically still need the ultrasound. Sometimes serial ultrasounds are needed if the first one is negative, but suspicion remains high.
Makes sense. And once a DVT is confirmed, management usually involves anticoagulation.
Yes, anticoagulation blood thinners is the mainstay of treatment for most DVTs. The goal is to prevent the clot from getting larger, and most importantly, to prevent it from breaking off and traveling to the lungs, causing a PE. There are several options. Traditionally, it involved starting with an injectable like low molecular weight heparin, LMWH, and bridging to warfarin. But now, the direct oral anticoagulants, or DOACs drugs like apixaban, rivaroxaban, edoxaban, dabigatran are often preferred. The 2016 guidelines of the American College of Chest Physicians actually recommend DOACs over warfarin for managing DVT and PE in patients who don't have active cancer, mainly due to their convenience and safety profile.
Okay. And what about those IVC filters? When do they come into play?
Good question. Inferior vena cava, IVC filters, are small devices placed in the large vein returning blood from the lower body to the heart. They act like a little basket to catch large clots traveling up from the legs before they can reach the lungs. They're generally reserved for specific situations. Maybe someone has recurrent DVT or PE despite being on adequate anticoagulation, or if they have a contraindication to taking blood thinners, like active major bleeding, or sometimes in patients who have a PE that's causing significant strain on the right side of the heart, right ventricular dysfunction, or another PE could be fatal. They aren't typically first-line therapy.
Got it. Okay, let's shift now to the more chronic side of venous problems. Chronic venous insufficiency, or CVI. What's the long-term picture here?
So CVI refers to the changes that happen in the leg due to long-standing venous hypertension, basically, high pressure in the veins. This usually results from damage to the valves inside the veins, which normally prevent blood from flowing backward. When these valves become incompetent or leaky, blood pools in the lower legs, increasing the pressure. This damage often happens after a previous DVT or sometimes after superficial thrombophlebitis or even significant trauma to the leg.
Okay, and here's where we get that interesting comparison with P8 again, right? The pain pattern is quite different.
Exactly. This is a really key distinction. With CVI, the leg pain, aching, or heaviness is typically worse with prolonged standing or sitting, especially with the feet hanging down, dependent position. And this is the opposite of PAD, the pain is often improved by walking, which uses the calf muscle pump to help move blood up, and by leg elevation. People often describe the pain as a burning, aching, throbbing, or cramping feeling, or just that their legs feel really heavy.
So worse with dependency, better with elevation and walking. What else do you see on physical exam with CVI?
The most characteristic skin finding is stasis dermatitis. This starts as an itchy eczematous rash, often around the ankles. Over time, you get this distinctive brownish or dark purplish discoloration of the skin, called hyperpigmentation. That's from hemocentrin deposition iron pigment from red blood cells that have leaked out of the high-pressure veins, stains the skin over time. Venous stasis ulcers are also very common, and unlike PAD ulcers, which are often on the outer ankle or toes, CDI ulcers classically occur around the medial malleolus, the inner ankle bone. They often have irregular borders and may weep fluid. And the absolute hallmark symptom and finding of CVI is dependent pitting leg edema swelling that leaves an indentation when you press on it. Pulses and skin temperature are usually normal, unlike in PAD.
Edema is the hallmark. So how do you manage CVI, especially that swelling and the skin changes?
Management is primarily non-operative, focused on controlling the venous hypertension. And the absolute cornerstone of treatment is compression therapy, wearing properly fitted compression stockings or bandages. This helps support the veins and reduce swelling. Leg elevation whenever sitting or lying down is also crucial. Good skin care is important to prevent breakdown and infection. Regular exercise, particularly walking, helps activate the calf muscle pump. Avoiding long periods of uninterrupted sitting or standing is also advised. For venous ulcers, compression and wound care are key, and sometimes aspirin is used as it seems to help accelerate healing.
Okay. And just briefly, what about varicose veins? How do they fit in?
Varicose veins are those dilated, tortuous, ropey-looking superficial veins you can often see under the skin. They happen for the same basic reason as CVI failure of the valves in the superficial veins allows blood to flow backwards. retrograde flow, and pool, causing the veins to stretch out and bulge. Risk factors are similar. Family history, being female, older age, jobs involving prolonged standing, obesity, pregnancy, due to hormonal changes and pressure from the uterus, and underlying CVI itself.
Are they always a problem, symptom-wise?
Not necessarily. Many people have them and they're purely cosmetic, causing no symptoms. But they can cause symptoms, often a dull ache, pressure, or feeling of heaviness in the legs. And characteristically, like CVI pain, these symptoms tend to be worse after prolonged standing or sitting and feel better with leg elevation or walking. Management starts conservatively with leg elevation, exercise, and compression stockings. If symptoms are bothersome or for cosmetic reasons, procedures like thermal ablation, using heat to close the vein, or sclerotherapy, injecting a solution, or surgical ligation stripping can be done.
Okay, fantastic. So this brings us to the big wrap-up comparison. PAD versus CVI. This is really where understanding those differences becomes so practical for you, the listener, because leg pain, skin changes, swelling, these are common complaints, right? Knowing these key distinctions can really help make sense of what might be going on.
Exactly. Let's nail down these key differences. Think about the skin. With PAD, remember, it's often atrophic thin, shiny, hairless. The limb feels cool or cold. You might see that dependent rubor, dusky red when down, or pallor cyanosis when elevated. With CVI, you see stasis dermatitis, that itchy eczematous rash leading to brownish hyperpigmentation. The skin might feel thick. The limb is usually warm to the touch and might look cyanotic when dependent due to stagnant blood, but not typically pale on elevation.
Okay, skin differences are clear. Now, the pain pattern, this is probably the most crucial differentiator day to day.
Absolutely. PA pain, worse with activity like walking or with leg elevation. It gets better when you rest or dangle the leg down, dependency. CVI pain, worse with prolonged standing or sitting with leg down, dependency. It gets better with walking or elevating the legs. Almost the exact opposite.
Got it. And the location and look of ulcers.
PAD ulcers tend to occur at pressure points, tips of toes, or classically the lateral malleolus, outer ankle. They often look punched out with clean margins. CVI ulcers are most common around the medial malleolus, inner ankle. They tend to be more shallow, with irregular margins, and often have weeping or surrounding stasis dermatitis.
How about the pulses?
With PAD, pulses in the foot and ankle are typically diminished or even completely absent. With CVI, because the problem is in the veins, not the arteries, the arterial pulses are usually present and feel normal.
And finally, that edema, the swelling.
This is a big one. Edema is relatively infrequent or minimal in pure PA. But in CVI, dependent pitting edema is the hallmark symptom and finding. If you see significant leg swelling, especially with those skin changes, CVI should be high on your list.
Wow. Okay, laying it out side by side like that really crystallizes the differences. What a journey through the vascular system. We've covered a lot, from the atherosclerotic processes in PA, the urgency of acute blockages, those less common but fascinating conditions like Berger's and GCA, and then shifting to the venous side with DVT and the chronic changes of CVI.
Yeah, and hopefully understanding these distinctions, these key signs and symptoms, empowers you. Whether it's maybe recognizing something subtle in yourself or in a family member or friend, or just feeling more equipped to understand health news or discussions, it really comes down to knowing what to look for and, importantly, knowing when something needs medical attention.
Definitely. So here's a final thought to leave you with. As you go about your day, think about how interconnected this whole vascular system is. How might symptoms that seem isolated, maybe just in your leg or your eye, actually be a subtle whisper from a much larger, more systemic process that's trying to tell you something important, something to ponder?